Courage after this fireside chat. Hopefully we don't go too long, and if you have any questions or anything on your mind, please feel free to ask. I think Diane and I'll speak for us both. We try to be pretty open-minded, pretty transparent, and I'd love to just share anything that we can help with. So I'll leave it to Diane.
Hi everyone. So I am from New York City. I had a private practice and I practiced academic medicine as well for 25 years in pediatrics and obesity. And then as my career went on and there was very few people, very little access to obesity medicine doctors, I started treating adults as well. And I think what Lauren and I have in common is that a lot of players in this industry take shortcuts, they don't follow the evidence, and I think we have a lot of pressure on our backs to do something quickly and get quick results, and we're up against a lot of misinformation from social media, Google searches, and I think we're going to try to break it down for you today. And it's nice to be on a panel where you know that you're going to agree with everything somebody else says, or I think we are a good, we complement each other.
All right, so I'm going to kick this off. We're talking about population health, preventive medicine, and I'll start with the softball, but don't worry, I'll get challenging as time goes on. So first, with obesity and your background in obesity medicine, and we hear a lot about GLP-1s. I'd love to know how you see GLP-1s and clinical outcomes in population health, and how does that matter? And I ask this because GLP-1s, we think about it for weight loss, but what does that actually mean for our healthcare system and population as a whole?
Well, I can tell you what I saw in private practice and what I know is going on and where I think it should go. So GLP-1s for a long time have been the wild west of obesity medicine. Most people don't know that GLP-1s were actually invented, or like they first were made in 2005. So most people think that GLP-1s are new drugs, and they're not new drugs. So we had a lot of experience with GLP-1s, using them with type 2 diabetics, and then we saw the nice benefit of the weight loss, and then we started studying them as weight loss drugs. So my biggest problem as a physician and working at ENED is that most people see these as vanity drugs. So they see them as, I have a wedding to go to, I need to fit into a tuxedo, I need to wear a prom dress, and it's something very short term. And actually I was on a panel last week, and my friend Dr. Agati from UVA was telling me about his research. He's an exercise physiologist, and that every time you lose weight on a GLP-1 and go off and go back on and go off and go back on, when you gain that weight back, 90% of it is fat mass. So you're even gaining more weight back than you probably would have, and it's much harder to lose fat, we know that. So I think, I'm aging myself out, but when I started working in population health at Johns Hopkins when I was an undergraduate, we had to call people on the phone to get information. We had to send letters out. We were reaching out to men in jails. I was studying HIV. It was very hard to do population health. Population health now with telehealth, where Oren comes in with the advent of the internet, smartphones, AI, we can get such granular data on such a large scale to really move the needle in people's health.
Great. Totally agree with a lot of that. Let's dig in a little deeper. Okay, so we have obesity and the reduction of obesity with GLP-1s. What are you seeing with other health outcomes? I know that I've seen a lot about cancer, and I've seen a lot about heart disease. What do we know about that space, and what does that mean for our healthcare system? I also see a high cost associated with GLP-1s.
Sure. So the problem is that GLP-1s are not accessible to everyone. And we know that people turn to compounds and different products on the market that we really can't study. So anybody who tells you, oh, I got a compound, but they've been studied, well, they haven't. They've been made, but they have not been clinically tried in any rigorous clinical trial. So I can only tell you what I've read and what my experience has been as a clinician and at ENED. So anybody who starts a GLP-1 without having biomarkers tested, you don't know what your baseline is. You might know your weight, and that's about it. So you really need to have blood tests done, whether you're doing it through the EMED program or through your physician. You need to know where you're starting. Are you pre-diabetic? Do you have a poor lipid profile? Do you have familial hypercholesterolemia? There's so many questions. Do you have inflammation? We know now we used to have a slide when I started GLP-1s of like what it could treat, and now the slide just goes on and on and on and on. So we know it reduces metastases in some cancers. We know that it decreases inflammation. So not just losing weight and improving your knee because you're bearing less weight on your knee. We have studies that are going to come out now that are going to show that GLP-1s have anti-inflammatory properties that actually decrease the inflammation in your body, and you're probably going to be less likely to get a knee replacement for those two reasons, not just the weight loss. So there's so many things, and I think that what I see is people coming onto EMED who are very used to getting a prescription for 12 months. The doctor doesn't want to deal with the insurance companies. They don't want to have to get the prior authorization every month. And really, your dose should be titrated every month to every 3 or 4 months at least. And they need to hire extra staff, like a physician at a hospital or a private practice doctor needs somebody, if they take insurance, to be on the phone all day to get prior authorization for maybe 3 prescriptions. So you need a whole salary for another person to get the prior authorizations for these drugs. There are so many roadblocks. And I think it's going to change. I think as the insurance companies realize that the cost of these drugs are coming down, but the cost of the other drugs and the other admissions, GLP-1s reduce MACE, major adverse cardiovascular events, which by 20 to 30% in some studies. So that's a huge savings to an insurance company, to an employer who's paying for insurance. So I just think that we have to do these rigorous trials because we need to convince people that they're just not a vanity drug.
So to summarize all that, it sounds like, and I totally agree, but the cost of the drugs have come down. There are prior authorizations, which is when the physician, and I do this a ton, and I'm sure you have, asks for permission from the insurance company to actually prescribe something and get clearance for it. And the benefit of spending that extra few dollars a month on the GLP-1s, to us, what I actually have to document, the benefit is so great because you can reduce other health or outcomes, what we said MACE. So heart disease goes down, right? In some cancers, it sounds like we may be slowing the progression of it. And so that's the benefit that I see also from my lens as a doc, that now we can prescribe something that has all these other secondary benefits. So that's a great example of population health intervention, where a drug can actually help reduce other health outcomes, potentially hospitalizations, etc. Everything has a risk benefit. There are risks to every drug. Whenever there's a benefit, whether it's talking about a medication that's FDA approved or a supplement, there are going to be adverse events, right? And so it's all a risk-benefit calculation, and that's something that you have to take into account when thinking about population health, right? We could talk about, mammograms and how effective they are, but should we potentially overdiagnose something and therefore you have bad outcomes, right? So that is what population health is all about, and public health is as well.
And I think now, with telehealth programs, we can reach people who never had access. There's no democracy in healthcare in this country, right? Healthcare is not a right in the United States; it's a privilege. And there are many, many people who have been disenfranchised and couldn't get the care that they needed. And with telehealth programs and apps, people can stay at home and see a cardiologist. People can stay at home and speak with an obesity medicine specialist. They can do a blood test at home from a Tasso device, and they can see if they're pre-diabetic or if they're already diabetic. Things that they never would have known, because many people in America, if they don't go to work, they don't get paid for that work. They can't afford to take a day off. They can't afford the babysitter to stay home with the kids. So population health, with the advance of technology, is really going to change the face of giving access to people who never had access to a drug. But with that, like you said, you need to have supervision and oversight.
So I'll move away a little bit from the GLP-1 because this topic is the future of population health and preventive care, and it's not all just one magic bullet. I think that in our society we're thinking a lot about health in other ways as well. I'll start with we're talking about diet, we're talking about exercise a lot more. You see this all over social media. I do think that there's a lot of noise. What are some of the misconceptions you see about all these lifestyle changes that are recommended as well?
Paleo, every diet somebody has told me about, somebody sent me an email about it or a text. And personally, I believe in the Mediterranean diet, which I think is really about balance, right? I tell my patients, you can eat well 85% of the time, 90% of the time, and then 10% of the time you can indulge a little bit, because I think that anything that's too strict is not sustainable. That's my personal opinion. Secondly, we were sent a sweatshirt to my company that said protein, protein, protein. And if I hear the word protein, sometimes I cringe because it's so much hype about the protein and how much protein do you need, and the truth is when you lose weight, you lose muscle mass in proportion to the weight that you are losing. And now with GLP-1s, I know you don't want to talk only about GLP-1s, but you're losing weight much faster, right? So we need resistance training. We need to do cardiovascular training. Life doesn't happen in a bubble. You have to carve out time for it. And there's no quick fix. If you do not exercise, your cardiovascular health is not going to be good. Power walking might not move the needle on the scale for you, but it's going to improve your cardiovascular health. It's going to reduce your risks of cancers. So I think that there's just so much misinformation out there that you have to think about a goal that you can achieve. Sometimes it's just stopping soda, like soda pop. If you stop drinking sodas, and we know a lot of people who drink soda every day, you're going to lose 1 pound a week just by cutting the soda out of your diet. There's about 12 teaspoons of sugar in one, soda that you drink, sweetened drink. So it's just about small changes. I once heard a trainer tell a child, he said, "Oh, you know what, Coach, I only did 2 push-ups today. Yesterday I only did 1." And he said, "Well, you doubled what you did." And you have to look at it that way, with that positive outlook. Small changes.
Awesome. Great. I will stop right there if that's okay, unless you have more, because I love the opportunity. I saw 2 hands go up in the back. But if there are any questions so far, I'd love to pause and give you all time to ask that. What's top of mind for you?
You're talking about the GLP-1.
Here we go.
The GLP-1 is always looking for more and more what it can be. But I understand that there is a lot of people that are becoming allergic to it or having a side effect of it, and it's not so.
So I can answer that. There's not many allergies. There are about 20% of the population just doesn't lose weight on GLP-1s, and that's their genetics. So about 1 in 5 is not going to respond. We see a lot of the side effects. Most of the side effects are gastrointestinal, like vomiting or nausea, or bloating, gas. When you use the lowest effective drug dose instead of the highest, we minimize that. And that's very important because some people go to unreputable doctors, or their doctors are just not educated. They escalate the dose very quickly, and that will lead to more side effects.
Thank you.
Go ahead.
You have to turn it on.
I'll just add what's really cool about medicine now that we hadn't seen before is that there's so much more information available. There's AI that can help, guide a lot of the care. And I say all that because genetics for people who respond to GLP-1s have actually been discovered. Now, genes, we say load the gun, environment pulls the trigger. So you may have genetics for something, but doesn't mean that the epigenetics, what comes out of it, phenotype actually comes out. So we do have genes to maybe predict what would work and what would not work, which I find really interesting. And from a population health standpoint, we're gonna learn so much more just given the amount of information that we have now. It's no longer trial and error as much, but we're gonna learn a ton. There's a lot out there. She had one question, the one with the microphone.
Yeah, 2 things you mentioned, Dr. Diane has, about the GLP-1. One was when the people gained weight afterward when they use it too quickly, that they usually gain more, if I understood well, more fat mass than muscle mass. So how could we prevent that, or if that's something that just happens? And number 2, you mentioned something, I was slowing down the progression of metastasized cancer with GLP-1. That's very interesting.
Yeah, so that's
very, very important for me, because I don't know if there is a lot of treatment, or actually if there is any treatment in regards to metastasized cancer currently. Right now, it's more like a deadly diagnosis.
Yeah, and it's not for all cancers, but a
Yeah.
study just came out. I can't think of the journal. I don't know which journal it came out about 2 weeks ago. And it was actually, I think it was also in the New York Times. So just, you can look it up. I don't want to misquote it, but definitely in 2 types of cancers. I think breast,
Oh, that's fantastic.
and maybe,
Because 50%
but
of the
also remember,
population has.
breast cancer, a lot of it is related to adiposity, just fat mass in general.
Oh, okay.
In breast. So, there might be correlation, not causation, and we have to look at
Okay,
this
I
in more
got it.
detail, but it definitely does reduce inflammation
Yes.
in certain pathways, and that's probably the mechanism of just reducing overall body inflammation.
And just to add, there's
Thank
no
you.
magic bullet,
Yeah.
so it's
Yeah.
in conjunction with, standard treatments too, but
Yeah.
it shows that there's some benefit to it.
No, yeah, I know. I'm asking the doctor, like, I'm a doctor as well. I got it. Thank you, doctor. Thanks.
What about, you mentioned already AI. Can you elaborate it and give examples?
Absolutely.
Well, maybe if you don't understand me, maybe she can translate to American accent here.
I understood fully. All right, so the question is about AI in healthcare, and I'll lean into imaging. Okay, there's a lot, and some of the research that I do actually is in layering AI on scans that you or I have already done, and find what we call opportunistic findings. So let me give you an example. There's, again, I'm a research affiliate, unpaid, but just so you all know, I do love this kind of research. So one company looks at different CAT scans and chest x-rays, but CAT scans seem to be a little bit better, that you may have had. Maybe you went to an ER for one reason or another. Maybe you just had a CAT scan for like a calcium score to look for plaque in the vessels. Maybe you had a CAT scan for lung cancer. Some people get a low dose CT scan. The question is, how do we find out more information? And so one of the things that we're doing is layering AI on top of it. It's a lot of work to actually look at what models are best. So let me give you an example. We all have fat on our chest, right? When you're looking at plaque in the arteries, right? There's different kinds of plaque in the artery. There's hard plaque. That hard plaque, that's what a calcium score is stiff. It doesn't dislodge and cause heart attacks, but it's old disease. And so when you get a plain calcium score, that's old disease in your vessels. But what if you look at the fat that you already have, which is not as dense, right? And you look for that fat inside the vessels. Suddenly, AI is looking at soft plaque. Soft plaque is dangerous. Soft plaque causes heart attacks and gets dislodged. So, whereas 2 years ago even, or actually this just got FDA approved in the past few months, you could say 6 months ago, you would get a calcium score, a chest CT, maybe you see some plaque in the heart vessels, you're like, okay, we don't know whether or not this is dangerous, it's old disease. Now you can actually layer AI and look at soft plaque that would potentially cause a heart attack. Then you can also look at the liver and look for fatty liver disease, right? Fat in the liver. You can look at the spine and calculate, a bone mineral density, right? Which a lot of women over 65, this is the Medicare guidelines. You're gonna go get a DEXA scan, right, for bone mineral density. Suddenly you could get this opportunistically while leveraging AI. Does that kind of make sense how it works in diagnostics? Cool. Yes, ma'am. Oh, sorry, she has a mic.
Yes, 2 questions. One is, I guess, for you, Dr. Hess, is when you talk about GLP and you talk about when people come off, it seems like worse. It would seem to me if you don't want to be on for the rest of your life, if you start it the way you explain it, someone will be worse off because you'll have all that fat. Is that correct?
They'll be worse off if they don't change their lifestyle, for sure. We know that you're going to gain weight back once you come off your GLP-1, and you're going to reverse all of your
And
metabolic.
why is that?
Because it's working to treat what you're genetically predisposed to have, right? So nobody tells you to come off a statin. Nobody tells you to stop your asthma control.
Yeah, but will I be but if I stop my statin, my cholesterol then, or my bad cholesterol will automatically go back to be worse than when I started. That's the thing.
Not everything is worse. I'm just saying the type of weight that you gain back is mostly fat.
Okay, the same. And the other part is for Oren is the way that I see your head of innovations at I guess they do cardiology. Is that correct?
Agustin does.
But your head of innovations, what are you doing in that?
Yeah, so it's a lot of, the example I use, for example, the calcium score, the namesake is the Agustin score, okay? And so what I'm looking at, and again, this is more of an academic thinking exercise that we have, is helping others figure out how to leverage artificial intelligence in clinical practice, which is what I enjoy to do.
Thank you.
Sure. Now I'll add one thing about the GLP-1 question, if I may, Diane. To answer your question, I think what happens is, so what Diane represented is a clinical study and the outcomes. So after 70 months or whatever it is, this is what happens, right? It's pretty objective. People are gaining weight. And I think, to Diane's point, maybe there's an aspect of this medication works. I'm losing weight, and possibly the habits that all of us should be doing, myself included, is maintaining an exercise regimen, maintaining an intake of, a varied diet, as opposed to relying on the medication. So that's probably why that exaggerated response when you stop the medication.
So your behavior is changing.
I wonder if the behavior changes, and it just hasn't been studied, right?
And the long-term effects, how long is really our studies now? That's my concern.
That study, the last study was maybe 72 months, so 5 years.
But do we know what's going to happen in 15 years?
We don't know what's going to happen.
Clinical trials were only just started a few
Right,
years.
so that's the issue too.
All right, who else we have about?
The white-
We have a mic right here.
Yeah, quick disclosure, I work in a pharmaceutical company on osteoporosis. I read your papers. So I'm very glad to hear about your discussion using AI to explore additional analysis for DEXA. But the question is, how important do you think it is to have some kind of checklist to make sure that all patients who go on the GLP-1 drugs have a baseline test of DEXA, for example, to make sure it is known what their score is when they begin, and check it a year after to see what their bone health is.
Yeah, so to rephrase that, because that's a great question, is you're starting a medication, there are unintended consequences, like potentially osteoporosis that develops for whatever reason, right? What kind of before and after. I will say it's not necessarily standard to do a DEXA scan before and screen for osteoporosis. I would also say that people who go on a GLP-1 sometimes do eat less and may have a calcium deficiency or nutritional deficiency. We've definitely seen that studied. Much of medicine and healthcare comes down to risk benefits, and I've alluded to that. I think for the right population, the benefits probably far outweigh the risk of osteoporosis, truthfully.
Do you see a trend towards more research and funding going towards preventative care? It seems to me that the insurance companies would do very well if that happened.
I think there are good things and bad things about this administration, but I do think that Robert F. Kennedy Jr. is very much about preventive health, and he's been trying to push the insurance companies to cover more preventative health. I know that you can disagree about his policies overall, but I do think that there is a shift, there's a change in the air. People want to have a longer, not necessarily a lifespan, but a health span. They want to live healthy for a longer time. And what we're doing now is I always say this to my patients who are kids, I feel like it's SpongeBob. We're just putting a Band-Aid. The water leaks and we put a Band-Aid. And what we do and what Dr. Mechanic does every day is he's trying to prevent his patients from this kind of care, that you're going to prevent it before it happens. I think.
So I'll add this. And by the way, we're at time, so when Sabina says we're off, we gotta go. But until then, we're good. Okay. That's a cutoff. I'd say, despite the efforts that administratively or HHS is trying to do with Be Healthy, the presidential fitness challenge is back, for example. I do think that I have to say this from a population health standpoint. There are things that are known to be proven to work to save lives, and it's the Pareto principle, right? The 80-20. We still have to maintain that attention on the things that we know work, and there's plenty out there that I think are sometimes at jeopardy with this administration. I think we're at time, but we'll take questions afterwards, okay? All right, I've gotten a lot of this. All right, thanks.
Mic number 2. There we go. Thank you, Dr. Hess, Dr. Mechanic. All right, stage is going to be closed for the next 30 minutes. We're going to start up again at 2:10. Thank you. Oh, thank you.